Okay, hello everybody. I am Mary Erickson, a program director for Mountain Pacific Quality Health, and I'm overseeing the task order that all the coalitions are busy actively working. So I wanted to spend some time with you today to discuss how we're going to work together over the next few years. And I'm just really excited to have everybody here and have this great attendance in our kickoff session today. So feel free to jump in the chat and say hello to everybody and get acquainted with each other. Just a couple of logistics. We have muted your microphones, but please try to keep them on mute. We did want this to be interactive, so you do have the capability to unmute yourself, so just be careful of that as you're listening, and we will we'll work to manage any background noise that might happen. This presentation is being recorded and it will be sent out to all the participants, all the registered participants, I should say, after the session, along with any handouts and materials. You can enter any questions as they pop into your mind in the chat box, and we will have plenty of time towards the end to answer questions, or if they're relevant to what I'm covering, then I'll go ahead and answer them at the time during the presentation as well. We know that a lot of you have worked with us for quite some time, and we'd love for you to share your experience with the coalitions and your successes. We have a nice mix regionally on this call today, and we have a nice mix of new coalitions and ones that have been existing. So please feel free to share your experiences and ask questions of each other. And of course, be kind. We're all learning together. There's been a lot of changes with this contract, and we'll get into that right now. If you worked with us in previous scopes of work, you will know that we were very state-based at that time. We were very specific task focused. In fact, a lot of you started with us working on care transitions coalitions. And some of the coalition work that you're going to see is expanding. And most of the emphasis previously was on working individually with nursing homes, hospitals, clinics, providers, and beneficiaries. So now we have a much more regional approach. We are cross-task and cross-setting focused. So we can work on several different areas at a time and across several different settings. So we'll get into more of the details of that, and hopefully I can make sense of what that means to you at the coalition level as we go through this today. The emphasis is really on working with coalitions and collaborations to achieve goals instead of so much individual work with hospitals and clinics. With the exception of nursing homes, we are still working individually with nursing homes, and they are also welcome and encouraged to be a member of coalitions. So we still have individual work we're doing with nursing homes. And the emphasis is really now on engaging beneficiaries in their care and in managing their care. So the regional approach, one of the biggest changes is that our recruitment numbers and all of our metrics are rolled up into regional outcomes. So our outcome evaluation metrics are no longer measured on a state-by-state basis. We will measure them internally that way and try to do some drill down with you into your communities and whatnot. But overall, Mountain Pacific's performance will be based on regional outcomes. So with that regional approach, we needed to change our staffing model just a little bit. So many of you that may have worked with us in the past, I'll make this a little bit bigger so you can see that handout. Many of you that worked with us in the past know that we had state directors in every state, and that the work was very state and task based. Now we still have local contacts in every state that you work with on the coalitions, but we are in more of what we call an account management model, where we have a couple of local contacts in each state that manage a lot of the work in that state, but we don't have any more state directors. We have myself as program director, and then we have Sharon Phelps, who's an additional quality payment program manager, and then Patty Kosednar, who oversees health transformation consulting services. And then the three of us oversee the work in all of the states, and then all of you have your local contacts in each state. So it's a little bit confusing, but you can let us worry about that. The biggest thing is you still have your local contacts in your states, and they're doing a great job at making sure local services stay and are available. One of the other changes that I just want to touch on briefly is that our funding structure changed from a time and materials model to a fixed price performance-based model. So now our funding is essentially broken into two different buckets: coalitions, which is where the bulk of our funding is going to happen, and then nursing homes is the other side of our funding. Our funding for nursing homes was cut pretty significantly last go around, which is another reason why we're really encouraging their participation in the coalitions, so that we can continue those relationships and continue working with them. Now, that being said, with all the activity that's going on in nursing homes with COVID, we are under a contract modification right now that is adjusting some of the funding for the nursing homes and the way that that support is structured. So I will be doing another kickoff call at some point for nursing homes once we get out of this modification proposal that we're in right now. That should be submitted later this month, and then we'll know more about how the nursing home funding is going to work out. But for this particular group, we really just encourage those homes to be part of our coalitions and part of that great work that's going on there in your local communities. So to talk a little bit more about this structure, so essentially this is just kind of an illustration of how the work has changed almost entirely to a coalition model as opposed to a task by task and setting model. The affected beneficiary community are the participants in state or local coalitions, and those that have agreed to participate in also in nursing home improvement work. So this work in the coalitions and the nursing homes will then also be supported by regional affinity groups. And we'll talk some more about affinity groups in a minute. And all of that work is, of course, to improve health outcomes. And a lot of what we've done because of this move to a coalition model, and why some of you are here today, is because we started out this contract work in November, and our first inclination was there's already a lot of existing coalitions, and we do not want to duplicate work in these areas. So you see where in some areas we've been able to align or come to the table as part of an existing coalition. And in some areas we just continued our own existing coalitions. And then there's a couple of instances where we've needed to start new coalitions. But for the most part, we made a lot of effort at trying to align with existing work and enhance existing work as opposed to duplicating work in your communities. So an affected beneficiary community, when you hear me use that language, these are the Medicare beneficiaries that reside in a community in which you are working to affect healthcare. And that affected beneficiary community is the target community that we have all been charged with improving the outcomes in. There were specific criteria that CMS made that we had to meet to include those communities. And some of them are much larger geographical spaces than just maybe your town or your small coalition. But what we are watching is, what is the area that you are affecting? So some areas, that geographically, the patients will come to from a rural setting into a more urban setting to receive care. So we have to adjust our coalitions based on where the community beneficiaries are also getting their care. So some of that is a little difficult to understand, but if you hear me use affected beneficiary community, that really is our lingo for the population that you are affecting, that is likely outside even the four walls of just your town or your immediate area. So hopefully that makes sense. An affinity group, the other language you saw in that last slide was an affinity group. And those are groups of people that have a common interest or goal and act together for a specific purpose. So these affinity groups will essentially be short-lived kind of work group settings where we might get together regionally if we've identified a need across several states. Then we'll put together an affinity group to tackle a project or tackle a problem together. It may be something that lasts 6 months. We recently had a telehealth 101 affinity group and it lasted 1 month. It's just going to depend on the need and what the group needs to do. So we're hoping that that will provide a good framework where we can bring subject matter experts to the table and target some very specific needs as opposed to everybody working on everything all the time. So, so this is going to be our effort to do that. The contract goals changed just a hair, not a whole bunch from the last scope of work, but this is kind of an overview of that. And then I also gave you, we also provided you with a handout that I will bring up that goes into a little bit more detail about the metrics of all of these goals. So the first goal is to improve behavioral health outcomes, including opioid misuse and decreasing substance abuse. The second goal is to increase patient safety in all care settings. And this is mostly around, these metrics are mostly around adverse drug events and infections. Goal 3 is to increase chronic disease self-management. So really, this is where the work continues on preventing diabetes, preventing hypertension, and they've added something a little bit new, which is preventing the progression of chronic kidney disease to the increased chronic disease self-management. Goal 4 is increasing the quality of care transitions. So that important work definitely needs to continue, and improving nursing home quality is goal 5. So you can see on this handout that I also outlined at the bottom some of the planned activities that we hope to do. And this is just a high-level overview to just give you an idea of how the work's going to be done. So we'll talk some more about the baseline data collection, but another piece of that planned activities is environmental scan. And a lot of times, you know, those are ongoing activities. They're simultaneous activities to other stuff that's going on. But these are the things that are kind of the bulk of what we need to do. The environmental scan is really just everybody staying in touch with what's going on so that we can collaborate where we need to and not duplicate work of other agencies and associations as possible or wherever possible. Collaboration and patient activation. Also, you know, we'll talk some more about those, and then implementing interventions locally as defined. So I did not make a cookie cutter list of the things that need to be done because I believe that the innovation and the problem solving all comes from you all that are the experts at the front line of the communities. So we're here to support all of that work. We'll do some more deeper dives as we go on some of the metrics as well, and I'm happy to answer questions about those today as well. Another key part of our work that isn't necessarily new, but it's got a lot more emphasis in this scope of work, and I'm very grateful for that because I think that it's been a huge oversight in past work. And that would be our vision for patient and family engagement and really getting the patient and family voices and experiences to shape the processes of care in our health communities. And I know that this is not something that everybody is completely comfortable with, or that a lot of people even really recognize how to do, you know, what is family engagement? What is patient activation? And so we have some great experts at the table. We have some great patient and family advisors at the table to help us make sure that we're able to do this. But our vision at Mountain Pacific is to start helping our communities make patient-centric approaches to the work and the processes that you're doing, and to do that at the front end and not just an evaluation of a process after we design it. Let's include them in the design of the process. So that's why we're encouraging you to get patient family advisors on your coalitions, but we know that that's a process in and of itself, and that takes some time as well. So we'll happily help you through that. We hope that we can assist them with technology trends and systems and utilize patients and families to help us with some of those technology trends that impact patients and families. One great way that we've had some patient family advisors help our telehealth affinity group work and guide some of that and make suggestions and provide us with some great input that's helped design our materials for our providers. We also hope that the patient and family advisors can help spread awareness of cultural considerations, individual dynamics, and improve health literacy. And then we also hope that we can help patients and families better understand their disease and take ownership of their health care. So just a couple of logistic things that I was asked to cover by some of the account managers to make sure that everybody in the coalitions understands what's required, because it is a little bit different than in the past scope of work. So we do need participation agreements from the coalition leadership, but we also need participation agreements from the community participants. So you can utilize, if you're an existing coalition that we've aligned with and you have your own form and you have your own agreement, then that's great. We can utilize those. So we just need something that indicates a commitment from the participants. It shouldn't hopefully require a bunch of legal review or anything, but I know some of you need to do that with your organizations, and that's fine. We can help get through that process as well. We are going to have to track participation and attendance on a regular basis. And if you stop attending or something, we may need to disenroll you from the coalition. We have not formulated all of that criteria yet because we're really just getting rolling. We haven't really had anybody that we felt needed to disenroll yet, but I just wanted to mention that today and make sure that you were aware that we're going to have to be more stringent about that because we have to report monthly to CMS who is participating in our coalitions. And, you know, as organizations may come on and off, we need to note that in our reporting. So I just want you to know that up front and right out of the chute that those are our requirements that we need to start meeting. In addition to that, we needed to make changes to our data sharing agreement that we had with previous coalitions because there were changes to our agreement with CMS. So hopefully some of the changes are actually make things a little bit more flexible than they were before. Not a ton, but a little bit more flexibility there. So this is in addition to the participation agreement, but the data sharing agreement, all organizations can sign the same agreement. But we just know that those are two different things, and we do need to have both for when we start sharing data, and that really protects both of us from, you know, HIPAA and covers all of the HIPAA rules and regulations that we'll be subject to when we talk about readmissions data or anything along those lines with the coalitions. So speaking of data, what is the status of the baseline data? So the baseline data, because we are in this modification and there have been some delays on the CMS systems and there have been some delays related to COVID-19, we have had delayed, this has all delayed our access to the baseline data. So they significantly changed the system that we utilize to get access to the claims data. It used to be kind of a download to us all the time. Now it's a cloud-based system. And so now there's been retraining and all sorts of things that we won't get into, but it's been a very significant change for the QIOs in the way that we access the data. So we're trying to do that and get that wrapped up as best that we can so that we can provide the coalitions with the important data that you need to start doing your work. So one of the things that we're trying to do is to prioritize the baseline data. We know that a lot of existing coalitions and some of the chronic disease coalitions and opioid task forces that we've aligned with are probably most interested in readmissions in diabetes prevention and adverse drug events. And some of these were monitored in the past. And so we can use old code and hopefully just refresh that data as soon as we get access worked out. So we are trying to prioritize some of that baseline data and get it out to you as soon as possible. The other thing that I'm putting together with our analyst team, and it should be ready, I'm hoping next week, is a data assessment and wish list that we'll put out to all of you coalitions so that you can let us know what kind of data support you need as it relates to the metrics. Are any of those of particular interest to your coalition, or are there additional ones that you would like to monitor? And then you can always start working on local process metrics for any current projects. So if you're working on anything locally, discharge planning together, you know, continuum of care kind of planning things, there's no holding you back on defining those process metrics. And if you need help with that, please reach out to your account manager and your coalition lead, and we can get you going on those local process metrics. So I realize that everybody has a lot of projects, especially these days, and very little time. So we do have a couple of polling questions for you so that hopefully we can prioritize what needs to happen in the coalitions. And we also asked the coalition leads last week to do the same activity. So if we could just take a minute here to go ahead and broadcast the poll, and we will see what people are thinking out there as it relates to patient engagement on a scale of 1 to 5. Patient engagement and activation is a priority for your coalition. So thinking more in the realm of your coalition, maybe not so much your organization that you're participating on behalf of, but your coalition. And then if you have any patient engagement and activation interventions in place already that you're working on with your coalition. And I'll give you just a minute. And if you are starting to have some questions roll around in your mind, go ahead and start entering those in chat as well, because we'll be coming right up on the question and answer period here in just a minute. Do you want to share the polling results, Lana or Mary? I'm not sure which one of you is running the poll. All right, good results. So most people are saying it's pretty high priority, and a lot of people don't quite have anything in place yet. So perfect. I think we have some PFAs on the call today, and Caitlin can take note of these results as well. All right, the second coalition or prioritization question is, in the past, your coalitions worked on the following, and go ahead and check all of them that apply. And I see a couple of questions starting to come in. All right, and do we have results from that polling question? And as suspected, we have a lot of care transitions coalitions on the call today, so that's great. I know a lot of you have been with us for a long time. So we appreciate those efforts and that work to continue. And it looks like med safety and maybe diabetes prevention are things that are high on the list. So everybody seems to have worked somewhere along the lines in a lot of our areas. So kidney health is fairly, like I said, fairly new area. So we're hoping for a lot of new partnerships around kidney health and that work. So thank you for your participation in that poll. We have one more polling question and then we'll go to the questions that are in chat. So the coalitions that are interested in working on the following. So if you could let us know what you're interested in, maybe the interests of your coalition have changed. Like I said, it's kind of, the work is now kind of opened up to all of the areas that we worked on are going to be worked on through coalitions. That's not to say all of you have to take on everything, but if there are other areas that you're interested in, please let us know kind of the hot topics of where you would like to focus. And speaking of hot topics, you know, just so you know, around COVID-19 and where the support for that comes into play, it definitely applies to a lot of our existing goals. It definitely applies to patient safety and infection control. You know, we've seen behavioral health and mental health become an issue with COVID-19. So we definitely, you know, we can support it under that. I really, you know, I'm hesitant to say that there's any area of our goals that it doesn't apply to in some way. So chronic disease and self-management also, you know, a lot of those patients and their ability to access care and monitor care has been affected by COVID-19 and the restrictions. So we have not pulled back any of our efforts. We're just kind of following along with what the coalitions want to do. And a lot of coalitions have used their existing coalition as a platform to solve some community problems around COVID-19. And I think that that is great, and we support that wholeheartedly. So please keep that important work and those conversations going. So it looks like in this poll that there are several coalitions interested in working on access to behavioral health. That's great. The next one in line would probably be diabetes prevention and some continued work on care transition. So definitely a lot of high interest in several of our areas. So we'll definitely take that into consideration as we start to move forward over the next few months. And so keep this priority conversation going at your coalitions as well. And we will definitely be spurring it on too. And I lied, there's one more polling question. So we're hopeful that interacting regionally would be of benefit to the group and to the coalitions. The coalition leads have felt like it was beneficial to hear from other states. So we're thinking of maybe having a regional quarterly call with all the coalitions and figuring out how to structure that. So we just kind of wanted to get your vote while we have everybody on the line. Okay, can you broadcast the results? Oh, look at that, an overwhelming yes. Yay. Good. Well, I'm glad that we're very glad to hear or to see that that is of value, or that would be of value to all of you.
Based off, sorry, Mary, this is Alana. Just based off a lot of you who registered in those questions, that the focus or the concerns that you all had input on, the majority that we were seeing was a lot of COVID prepare and addressing COVID, whether it's indirect or directly to your facilities. So I would guess that we would, if we put up topics with information regarding COVID for the first couple regional quarterly calls, I think that would be welcomed. But if you have suggestions on specific topics or concerns that you have otherwise, you can email them to myself or Mary or any of your account managers at Mount Pacific too.
Yeah, and we'll try to keep our keep our finger on the pulse too, what's going on with your coalitions, and any needs that you might have, so that we can try to make sure that we address those even regionally as well. Okay, so I see a couple of questions in chat. Lance, hello Lance. What is the status of Kauai County? I think Mark and Maggie have updated you on that, so let me know if you need more information. In terms of data, will you be getting this to the coalitions, and how you'll be getting the ADE and diabetic data? So that part of the data sharing agreement that changed a little bit was that we can send it through a secure electronic file transfer, which is a little bit different than how it might have been transitioned to you in the past. We can also view it electronically with the coalition. It just can't go anywhere after that. So it'll be coming, we're working on that secure file transfer. That's part of a little bit of the delay, is working out which systems with CMS that we can use, because they have a file transfer system that we are trying to get access to for our organizations and coalitions. So some of the things that are causing delays are us trying to work on better processes for coalitions and whatnot. So more to come on that. That's hopefully answers your question. And yes, the goals have been set up by CMS to be very disease focused and refer us to the IHI report about health and aging. Yeah, and interestingly enough, you know, I just got off a call earlier today with our professional organization that supports us. And we are having another conversation about that, exactly, that some of the metrics are very provider focused and they're very disease focused. They're very payer focused. And so we are looking at other metrics that are maybe more community driven and patient and health driven. So yep, I will take a look at that report too for some other thoughts there. So yeah, we're still working on that. And you know, while our metrics kind of are what they are from CMS, if there are other things that are more relevant for you to look at a community level, that is absolutely within your purview to do that, and we can help you frame those. And in fact, I encourage that because sometimes those examples of that community level data and us being able to give that to CMS and say, hey, we're showing, you know, this correlation with this metric and it's more effective than maybe the one that's been assigned for the QIO, then sometimes we can make changes, and that's how, you know, change happens, is by some of those ideas that come from all of you. So I appreciate that feedback for sure, and agree with what you're saying. So I just kind of want to ask all of you a question and see, you know, what's going to be the most helpful thing that Mountain Pacific can do to support the success of your coalitions. Don't be shy. And then Alana also put into chat, how has COVID-19 affected your coalitions? I know there has been some concern brought to me about whether or not you could utilize COVID or your coalitions for COVID-19 stuff. Absolutely, go for it. I think that wherever you can troubleshoot those issues, you know, you should be using whatever platform you have available.
And feel free to speak up too. You can just unmute yourself if you have, you want to speak up questions or comments or anything.
This is Terry Kendrick. I'm from Missoula, Montana. Who are the Montana Coalition members?
You mean that are here today or?
No, that make up the Montana Coalition.
Well, we have 5 coalitions in Montana, right, Alana?
Yep.
Sorry, don't mean to hesitate there, but I just want to make sure. So we have 5 coalitions in Montana, and are you looking for maybe some contact information? Would that be useful?
Yeah, like someone in Missoula. Someone in Missoula.
Well, Amber Rogers is the Mountain Pacific person in Missoula. But if we can connect you with the rest of the Montana coalitions and the Missoula coalition, that coalition just started. And it may not even be completely off the ground yet. So Alana, can you connect with her and Amber?
Yep.
Oh, Amber's on. There you go.
That'd be great.
Okay, we'll get you connected and in the loop.
Hey, Mary.
Yeah.
Do you want to speak to coalitions being virtual? A lot of coalitions are used to meeting in person, and so with virtual, we can get a lot more input and people from different communities. Do you want to speak to that?
Yeah, and several of them, like Crystal said, have transitioned over to virtual. And if you need any help with that, I know I see Leslie in Kalispell, Montana, has also kind of switched over her meetings to virtual. So I think for the most part, I think I'm hearing that that's going okay. I know that Alana and Mark and Maggie put together some kind of support questions and information for all of you to help support that. So we can definitely do that. Crystal, is that at all what you mean for me to update?
Well, sure. We had a virtual coalition meeting in Casper, which it was just new to everybody. It's different, but we just had the attendance was very good, and so we're going to start doing virtual Wyoming coalitions. So in the rural communities, we can cluster them and just have more ideas, more people at the table. We all have the same problems, and so hopefully, again, it's something new for everybody and it's something to get used to. So I just wanted to kind of introduce that because a lot of coalitions were meeting in person before.
Borgenicht, and I have some, as I've indicated, some concerns about what CMS is sending out. But I also am concerned about a lot of what CMS is sending out involves a hospital. And so as a community coalition, the hospital has all these projects going on. I'm in Bozeman, and we have some connection with it, not 100%. And we started out as a transitions committee, and we've now morphed. But that communication with the hospitals, I think, is actually more complicated. And then getting, they're already doing a bunch of stuff. And so then we would be recollecting stuff that they're already doing, like behavioral health. Bozeman Health right now is doing a big behavioral health push. I don't know how much of it is reaching the Medicare population. I don't think it's necessarily set up for that. I'm just concerned about how that communication or how that interaction is going to work, because they also have their whole diabetic clinic, and so we can impact out in the community, but impacting within the hospital is going to be much harder, I think.
Yeah, and I think definitely the hospital is a lot of times a key player in a lot of the coalitions. We see different structure across our region based on what you're working on and just whatever the environment is. Some hospitals are more involved than others, so if we find that that's a need in your community, then we'll see what we can do to help get them to the table and to make that relationship happen. Because I think it really does, it takes everybody. I mean, it's not there's not one way. There's not one way to fix it. I did see one question from Amber Jackson Jordan. How do the coalitions differ from other meetings we've had, such as care transitions, and who is our local representative? So Amber, if you could just let me know where you are from, unless somebody knows and can speak up and claim Amber. The care transition meetings, those essentially were care transition coalitions, and essentially what's happened is that CMS has asked us, they've said, okay, care transition coalitions worked, and so now we want you to do all of your work using coalitions. So now some of the care transitions coalitions are starting to reach out into other areas like behavioral health access, and in some areas we have aligned with chronic disease bureaus and Million Hearts initiatives in states. Instead of creating another coalition, we're just trying to come to the table and be a good partner with Million Hearts and supporting chronic disease efforts. So it does look a little bit different. It's, coalitions are an organic thing. Alana and I and Maggie and Mark and I talk about this all the time, that they're not a cut and dry, like this is, all they're going to do. There might be more that you can do now outside of care transitions if your coalition's willing to take that on. So Gillette, Wyoming. So Crystal and Eileen. Is Eileen Ford on?
I
Yep.
am on, yes, and I am brand new to this
Yep.
working. Just really looking forward to working with the folks in Campbell County and the Gillette area, and I have 2 other territories in Wyoming as well. So the one is designated as the Western Territory, which if you don't see the map, it doesn't really make the designation isn't true West. But I've started reaching out to people in that territory, as well as what is defined as the Basin Territory in Wyoming. So I definitely, within the next really short time period, want to get meetings going in those 3 areas and really start supporting the work that you all need to do in your areas. So Amber, I'll be working with you.
Great. Thanks for speaking up, Amber, and thanks, Eileen. So yeah, as you can see, we have, kind of a gamut of things going on. I know we had one new community. Missoula's a new community in Montana. Alaska, we had to really revamp some things up there and have aligned with Chronic Disease Bureau there to do some work. Wyoming, I think we have 4 or 5 new communities that we have to work with. And then in Hawaii, we had about 4, and correct me if I'm wrong, you guys, 4 or 5 new communities that we needed to work with. So yeah, there's a lot of activity. So if we haven't reached you yet, we definitely will. We're getting everybody rolling between contract modifications and pandemic planning. So we'll get everybody figured out. Go ahead.
Mary, this is Catherine Borgen again, sorry. But I'm curious with CMS, given these 5 places that they want us to look at, is there a minimum? What is the expectation from from CMS for the coalitions to accomplish? Or if they take one of these goals and then come up with other goals that they think are more appropriate for their community, will that also be okay? Does that make sense?
Yeah, I think so. I think I'm understanding your question. So we will have outcome evaluation metrics for all of those goals. So their minimum expectation would be that that we would meet the outcome metrics for the goals that are set. I'm not going to share those with you right now because we're under contract modification and we're revamping some of those goals and those metrics. So if you have other things that you want to work on that are not covered in the realm of those goals, then we would just want to evaluate that with you, probably on a case-by-case basis, and see, and see where it heads.
So I guess
most of the time we can find a way to work on what you need to work on, and meet, you know, and still support the coalition and meet what needs, but we just need to work on it probably case by case.
So basically, those are the goals. And
Mhm.
so the coalitions have to figure out how to meet those goals, given that they may not be what's really needed for the community.
Well, I guess what I'm saying is hopefully somewhere in those goals that they're high level enough that we could find a way that those goals would work within your realm.
So let me, I'm sorry to go on about this, but I have some real concerns. For example, the quality of care in nursing homes,
Mhm.
that's a major big deal. And for a community coalition to look at that and do something really actively to improve the quality of care in nursing homes is a very, very multi-tiered problem and issue. And so I don't see where we as a community coalition are going to have a lot of.
Yeah, and just to remind you in the area of that particular goal, from the coalition standpoint, I think, you know, having nursing homes involved in your coalitions and working on things like care transitions and substance abuse and all of that is definitely appropriate. But also remember that we have an additional bucket of funding where we are working directly with the nursing homes on that particular goal. So that's not one that I'm worried too much that is going to be reliant on the coalitions to support. But you know, we can take this conversation offline and I can work through that with you and Alana for sure. But keep in mind that is an area where we have additional funding to help support that work and work with them directly as well. Will you have access to the outcome metrics I showed? Yep, there should be a handout. Alana, did you send that handout and the slides and everything out? We'll send all of that out after the session. The session is being recorded, so they'll clean up the recording a little bit and then they'll send all of that out.
Yep. And I had put my email in chat, so if there's any other information that you guys are looking for, please reach out to us and we're happy to get that to you.
There was a lot of stuff going on in chat, Alana. Did I miss any key questions? That's good. I'm glad. I just want to make sure I didn't miss something. Looks like
not really. Just I definitely want to give kudos to Leslie. She said that they're going to be doing a supportive discussion around grief related to COVID, including self-care for their next virtual meeting on June 24th in Kalispell. So that's awesome.
good deal. And I saw some kudos to Mark and Maggie from Kristen in Hawaii.
Mm-hmm.
Thank you. They've been leading coalitions there for several years and had some great success.
Aloha. Hi, this is Kristen.
Mm-hmm. Hi.
Yeah, hi there. Happy to participate today. And yeah, we get a lot of support from Maggie and Mark. And I've been a part of the coalition for several years now and now actively co-chairing it with here in Hawaii. And the past couple of months have, getting back to what you were talking about with COVID, so we initiated the community partners to come and have virtual meetings. We've had 2 successful meetings, and the last one included telemedicine, which is something we've had to implement here. So that was really, really helpful, as well as, you know, making sure everybody was on board with the testing. And then also how to go from discharging from the hospital to the long-term care facilities to be able to get those patients to transition to that next level, having the COVID concerns. So a lot of good stuff, and we're moving towards our next meeting, which is coming up at the end of the month, and trying to plan on, you know, that phasing in from, or phasing out rather, from COVID to, okay, post-COVID, mental health, the ramifications of the economic downturn and things like that, which people are very, very concerned about, especially here in Hawaii, although we have the lowest COVID cases, we have one of the highest unemployment rate.
Yeah, which, you know, the economic impact, I think, is going to be longer lasting, unfortunately.
And that was definitely a reoccurring concern from the folks who put that in registration questions, was the economic impact from COVID. Also, a lot of PPE shortage, a lot of equipment shortages, cost of care, delayed treatment. So we're definitely paying attention to all that, and it's good for us to see frontline, and we definitely want to know what the frontline lessons and some of the tools and resources that are being put into place, so we can practice sharing that across all the coalitions and, like you said earlier,
Right.
efforts.
Yeah, I know. I think we're going to be focusing also on social determinants of health.
Mm-hmm.
Yeah.
All right, good deal. Thanks for sharing. Appreciate you jumping in.
Thank you.
Just a couple of other things as we wrap up here. Just a quick coalition checklist, the participation agreements, data sharing agreements, and the timeline on those is, you know, as soon as possible, especially if we're going to start sharing data. We're hoping to have some data in July if we can use some of the old metrics. So if we can get those things signed and wrapped up by then, that would be great. Our official recruitment will go through until November now. It's been extended as a result of COVID. So that's good. But if we're going to start sharing data and things like that, we do need to get those agreements signed. And then the data assessment wish list tool, coalition leads, I'll be getting that out to all of you through Alana and Mark and Maggie. And then go ahead, you know, with any local process metrics, you know, any of your local community things that you need to start addressing, and whatever we can help you with that. The handouts that you'll get from today will be the team contact information and the measures and planned activities. We have several things. If you have not been to our website lately, we have lots of blogs. If you want to get our updates that we're putting out by our medical director on COVID, then you need to sign up for the Healthy Living blog. And then of course, there are lots of other things. We also recently launched a telehealth website, which we will also be launching a telehealth blog series through that website as well. So lots of tools and resources. We're also going through a process of just reviewing materials and kind of revising things that are out there. So if you see things that we need to change or you have suggestions, we'd love to hear about those from you as well. And so for more information, we have a couple of upcoming things. One thing I wanted to mention, the nursing homes are facing some NHSN reporting starting really soon with some penalties for that. If you're not reporting, we're going to do an open office Q&A session on Monday, this coming Monday. I believe, if you want more information on that, let me know. I don't want to mess up what time they decided to have it. So we will be doing that session, and we'll be doing a weekly open Q&A just on NHSN reporting, because we know people are kind of having some struggles with that as well. And then we're also going to do a post-acute telehealth affinity group session on Monday, June 1st at noon Mountain Time. So hopefully, I know our last one was at 10 Mountain Time, which was a little early for Hawaii. So we thought maybe we'd push that out a little bit, and hopefully others could join. Alana, Mark, Maggie, Crystal, anybody have anything else that I needed to cover that I didn't, or any questions that are out there?
Not that I can think of.
Great.
I just want to say thank you to everybody This was a great opportunity, first time we did it. So like we said, we're still learning, and we're very grateful to be learning from you folks. So thank you very much.
Thanks, Mark. Thank you, everybody, for your great participation today, and I will give you all 5 minutes before your next meeting.
Yay.
Or at least
Yay.
some of us who have. But there's many of us in that boat these days. All right, thanks, everybody.
Thank
Have a
you.
great day.
Thank you.